Hello, everyone. I am Chris Henderson. I am going to be your guide this evening for the next hour-ish as we talk about this issue. And oh, Nikki just did the Facebook Live, yeah, because I didn't really give you a chance to do that. Okay, yeah, I'm Chris Henderson. I'm a part of Amistad Law Project and also the Treatment Not Trauma Coalition. And we have a pretty exciting evening for you. We're definitely going to have some time for questions at the end, but definitely feel free to pop into the chat questions that you might have along the way. We have some really amazing folks from the Treatment Not Trauma Coalition. We're going to talk to you about our work and what a mental health crisis response in the city could look like. Let's see, if folks could drop into the chat what brought them here tonight, and also where you are located geographically, that would be really great. I'm seeing some familiar faces on the screen. That's always great. Looks like some folks in Philly, some folks in the sort of greater Philadelphia area. One person in New Orleans, close to Philly. Awesome in Chicago, Denver, whoa. Philly in West. Awesome. Thank you so much. You guys can keep dropping in the chat what brought you here. But without further ado, I'm going to pass this over to Layla Khalil. If you're here right now, Layla. Maybe Layla's not here right now. Maybe she stepped away for a moment. So I'll keep talking for another minute. But yeah. Oh, what did you make? Nikki's making a face, like maybe you're thinking something. No? Okay. Just kidding. Okay. I think I'm actually gonna pop it over to you, Nikki, to talk a little bit about what the Treatment Not Trauma Coalition is.
Hello, everyone.
No, Layla came back. Hi, Layla. Okay. Can I pop it over to you to introduce yourself and talk a little bit?
Yeah, absolutely. Thanks, Chris. So sorry about that. I didn't realize folks we were going to jump so quickly. I was in the bathroom, so apologies, everyone. But I'm happy to be here today to chat about the different programs that the city's rolling out in response to some requests from the police department to have a better and more informed, trauma-informed response to emergency mental health crises. And I should just say that before we begin, my name is Layla Khalil. I work for the office of Council Member Kendra Brooks. And she's really sad that she couldn't make it today. And I hope that I can, be 10% of what she would provide for us. With that said, again, the Department of Behavioral Health and Intellectual Disabilities wanted to improve what was originally just a police-only response to emergency mental health calls. And they began working with many folks on this call to develop what each of these models would look like. And so there's two models that are being put forward by the city and the administration. The first one is called the co-responder model, and that model was rolled out a couple of weeks prior to the murder of Walter Wallace that took place last year on October 26th, 2020. And this model is essentially meant to be including a clinician or social worker who would ride along with a PPD officer or a law enforcement officer on calls that are deemed to be a mental health crisis. Any law enforcement officer responding under that co-responder model would receive crisis intervention training, also called CIT training by the Department of Behavioral Health. And this model is really lifted up to protect clinicians and social workers in instances where an individual is showing quote unquote potentially violent symptoms of their disability, including if a weapon is present or if a crime is taking place. And I know that many folks on this call have really helped illuminate and shine a light on why we need to really question the presence of law enforcement in the first place. And I'm looking forward to hearing more of those concerns. And I think also should just say that those concerns really resonate with Councilmember Brooks in our office as well. Over the budget cycle, we really began to question the Department of Behavioral Health and the police about the co-responder model in particular. We asked about CIT training, and it became really clear that the same issues that we were seeing with police response initially could still be very real issues under the co-responder model as well. We asked if law enforcement is still justified in using their firearms during these exchanges, and they are still justified. They're still permitted to use their firearms at their own discretion. And CIT training also doesn't override police academy training, which instructs officers to use their firearms against people they perceive as threatening. And that's really, really hard to combat against if folks are saying that they feel threatened. It's a really, really difficult sort of objective reasoning to kind of go over. That academy training is often also used by police officials to avoid any accountability for any wrongdoing that may have taken place by an officer during an emergency mental health response. So I think those answers really raise flags for us as well. The second mental health response model that's being rolled out by the administration is the Citywide Mobile Crisis Units teams. And this program already existed prior to this current budget cycle with one citywide mobile crisis unit that provides a 24/7 response in Philadelphia, and that's through JFK. The West Philly Consortium also provides a daily program that's slated to move to a 24/7 response based on budget allocations from this year. And so in total, after this budget cycle, as proposed, the city would have 4 mobile crisis units citywide. I just want to say, expanding to 4 units is direly needed. Many disability justice advocates that we work with in our office have reported that the response time for the current units is at least an hour. And sometimes the units are beyond capacity and can't report to an emergency at all. And I should really, say that these mobile crisis units are fully civilian responders, folks who have a lot of experience being within the community and de-escalating mental health crises and working with folks to connect them to services or bring folks to any hospital or other provider that would be able to help de-escalate the situation and bring folks with more services that would help them avoid these emergencies in the future. And, I will just say that we really need to work on fully funding these units so that people don't feel like law enforcement is the only response that will show up. Philadelphians shouldn't feel forced to choose between, an underfunded city service and the potentially dangerous response of law enforcement when thinking about how to keep their family and loved ones safe during a mental health crisis. And there are a few champions on city council who really understand this tension. And Councilmember Gim has been a real leader on parsing out the issue alongside Councilmember Brooks and Councilmember Gautier. So I'm really excited to hear more from Councilmember Gim when she joins, if she's able to join us, to hear more about those tensions, and I'm happy to stay on and go through the chat and answer any questions that folks have with greater detail. And yeah, I really appreciate folks being willing to have me join on today. Thank you so much. Thanks, Chris.
Thank you, Layla. And yes, I do see Councilmember Gim here. So without further ado, I'm going to pass it to you, Councilmember.
Hi, good evening, everybody. And thank you to Amistad Law Project. I want to thank the Treatment Not Trauma Coalition. And I want to thank everybody who's on here for taking time on this important issue of what we need from advocates right now. I want to open by saying that Walter Wallace should be alive right now. He would be alive right now if we did not, as a city, we had trained health clinicians, social workers responding to clear crises of mental health with support, with trained personnel rather than untrained police officer with a gun. I want to thank the Treatment Not Trauma Coalition for the tremendous work that you've been doing over the months to ensure and push the city to develop a real meaningful response for people in mental health crisis. Thank you especially to Amistad Law Project for providing space for all of us to learn together this evening. I want to thank Layla and acknowledge the work of a number of different colleagues' offices who are on here, most especially Councilmember Brooks, of course, but also Councilmember Gautier and a number of other city council members. And I'll say a little bit about myself. I've been deeply involved in this issue over the last year, particularly through my work with national partners such as the Justice Collaborative and in partnership with other council members to really seriously rethink policing and to consider, most importantly, alternatives to policing, working to build our way towards a system where the police are not the first people called, are not the only people that are considered an option, and instead that we bring and promise that our communities, when they make an urgent call for help, actually get a chance for help from people who know how to deliver it. I want to be really clear that we have to work together on all of this. This is a situation I think that we're going to hear about where the city has developed what's called a co-responder model that many of us on city council feel uncomfortable with. Believe that we need to be doing all that we can to ensure that it is the mobile crisis unit that is actually the one that is funded, invested in, and propped up and expanded. People need to be able to call for help for someone in crisis without fear that police may arrive and escalate the situation. What we know about the co-responder model is that they can't make that guarantee with that model, right? The co-responder model is not even clear that there is a co-responder. We have gone through a number of different budget hearings where we have heard that there are only a handful of CIT trained officers. The department itself is uncomfortable with the co-responder model, in part because their own protocol requires that 2 officers arrive to the scene, so they don't actually want a civilian on site. So all of this reminds us that we are here to ensure that we actually want to uplift the mobile crisis unit. We want to centralize, expand it. And the city of Philadelphia has currently committed to $7 million to, I would say, pilot a mobile crisis unit. It's it's only 4 mobile crisis units throughout the entire city of Philadelphia. It's not a needs-based number that was arrived at. It was simply like a pilot amount that was discussed. The co-responder model, as you'll hear on the teach-in today, is $6 million with police vehicles, equipment that's kind of associated with it. And a lot of us are here because we have a lot of concerns. But I will say that as a member of council, I'm in particular asking for, if you are here for this teach-in, we actually need your help. And what I mean by your help, we actually need your voice. We need the voices of communities to let the city know that the co-responder model is not going to work. It's not going to actually be ideal until we have a fully responsive mobile crisis unit. And that will not just be about a small pilot of 4 mobile crisis teams that are deployed, but actually a complete rediversion of mental health away from its current iteration of having police response to a fully non-law enforcement response. You know, as we've been working on this issue alongside with Amistad Law Project and led by the Treatment Not Trauma Coalition team, specifically, I want to highlight one additional issue, which is that we do need to find and figure out additional supports for our 911 dispatchers, particularly to improve their working conditions. Many people would think that 911 is a police department. They are actually not. They are supervised by the police department. They are city workers. They are civilians. They do not go through the police training. And actually, one of the things that we've been dealing with 911 has been some of the difficulties that many of them have gone through while being supervised by civilian police officers. At one point, some of the struggles that the 911 dispatchers have experienced mirror a lot of the complaints that people in communities have actually had about their experiences with the police. So we are very clear that we want to see civilian management of our 911 dispatchers. We don't actually want them to be supervised directly by the Philadelphia Police Department. This is very similar to what happens in the fire department, for example. We want to continue to support their request for higher pay, which is currently underway, and to ensure that their schedules are humane. They will be among the frontline individuals, and the good news for the Treatment Not Trauma Coalition is that they are also civilians. Many of them are Black and brown workers who are being paid far too little. And I think that we will see a united effort on this. But right now, we have a limited budget cycle until probably mid-June. The budget will be finalized by June 25th, I believe, or June 24th may be the date. So your partnership right now over the short term, and I will say this is a sprint and it is not the marathon right now. This is the sprint, is our chance to activate the people who are on this call who cared enough to take a couple of hours tonight to learn more about the importance of all of this, to join the Treatment Not Trauma Coalition, to join with the Amistad Law Project, and to start being advocates for this, to ensure that we can see a real funding on the mobile crisis. And after our budget is done, we have another opportunity to continue to grow this effort. It doesn't mean that things are done and over with after a budget, but I am partly on here to add urgency and to underscore the importance of your presence today, and to ask that this is not just about a chance to learn, it's about a chance to transform. We have a chance to do that right now. I really want to thank again the folks who have been leading this locally, the Treatment Not Trauma Coalition, and grateful for all the work that people who are on here are doing to lead us towards a complete transformation about how we look at policing, mental health crises here in our city. We do it in the name of Walter Wallace. We do it in the name of his family. We do it in the names of all those whose names we may not even know, who preceded or who are currently or who will follow in those footsteps. And thank you so much, Chris.
Thank you so much, Council Member. And I'm immediately going to pop this over to Nikki, who's going to talk about Treatment Not Trauma Coalition.
Unmute myself. Okay. Hi, everyone. Can you see my screen, first of all?
Yes, but it's not in present mode, by the way.
And I don't know that it's gonna be, but let's
Okay.
let's see if I can do that. Anyway, welcome tonight. Thank you everyone for coming. Oh, I guess it is gonna work. So we are the Philadelphia Treatment Not Trauma Coalition. You've heard Council Member again mention us this evening. So a little bit more about who we are. We are social workers, nurses, attorneys, and neighbors who have seen firsthand the challenges that arise when police respond to those experiencing a mental health crisis. Our group was formed in response to the murder of Walter Wallace Jr. in West Philly. We want to increase investment in mental health crisis response, and we want it to be trauma-informed and clinician-led. So what we've been doing over the past several months is that we've been doing deep research. We've been doing info sharing. We've been talking to folks in other cities who have been doing similar work. We've been interfacing with City Council, as you heard, and the Department of Behavioral Health to figure out how we do this in Philly. So that is who we are. When we formed, so we're grounded in abolition. That's one of our core values of this coalition. And I like this Mariam Kaba quote that we are not abandoning our communities to violence. We don't want to just close the police departments. We want to make them obsolete. And so talking about abolition, I also love this Ruth Wilson Gilmore quote that abolition is about presence, not absence. It's about building life-affirming institutions. And so how I have to think about it, give me 1 second. As I think of—
Playing from desktop P588JG.
I like to think about the Treatment Not Trauma Coalition as a part of building a life-affirming institution. I apologize for my background noise. All right. At this time, I'm going to pull in a few of our members, but just to introduce the problem that we're talking about. If your house is on fire and you call 911, the firefighter comes. If you have a heart attack or break your leg or anything like that, and you call 911, a paramedic comes to your house. However, here in Philly and in many places around the country, if you're having a mental health crisis and you call 911, right now the police come to your house, not a trained mental health clinician, and we know this is a problem because we saw what happened to our neighbor, Walter Wallace Jr. So, what we're talking about tonight is that we believe that Philadelphians experience a mental health emergency deserve a safe, timely, trauma-informed, and clinician-led response. Our first question and I want them to introduce themselves as they speak, from our coalition members, is what happens when police are the first responders for mental health crises. Maybe we'll start with Julia.
Hello, everybody. Yes, Nikki, Nomi and I are gonna alternate slides to make it easy. Hello, everybody. My name is Julia Lyon. I'm a licensed social worker. I'm a therapist. I am here. Oh, the slides went away. That's no good. I am here as a member of the Treatment Not Trauma Coalition because through my professional experience, I've witnessed how destructive the police can be as a force and how vulnerable people who experience emotional distress or the symptoms of mental illness are. And so basically, there are some common sense reasons why the police being first responders is a really bad idea. I like to say that there's a formula, right? So the police, first of all, are trained as soldiers. So they act as like a military force very often. That's how they approach situations. And their very training is sort of in contradiction to the principles of de-escalation. On top of that, for another ingredient, that formula is that they're armed. Another ingredient to that formula is that they, like everyone in our society, has experienced racial trauma, both the racial trauma of people who have been had violence and oppression committed against them because they are Black or brown or indigenous or a person of color. And then we also all hold white supremacy inside of our minds and our bodies in very deep places that are not always within our control or conscious, right? So we tend to perceive Black and brown bodies as threatening or more threatening than lighter skinned bodies. And for police, this gets reinforced through their training and their experiences and how they teach each other. So police always escalate a situation. That's for starters. Second, there's the criminalization of people with mental illness. I'm imagining that many of you are aware that the US prison system is the largest provider of mental health services in the United States, and they're a pretty piss poor provider at that. So when you have police show up, they are more likely to perceive a crime happening, see a crime happening, even if it is a nonviolent one, and there's more likelihood that they will be arrested or incarcerated, where they'll probably be further traumatized and not have access to services that they need or have their original problem that the crisis was caused by solved. There's obviously an increased likelihood of injury or death for anyone, but given the formula that I described for Black and brown bodies, there is a special danger, huge danger. There's also a decreased likelihood of connecting to the actual needed supports and traumas because the police are not helpers. They are not healers, and they cannot actually solve any ongoing problems unless the problem is the commission of a violent crime. So they can't actually get you access to a hot meal or a ride to somewhere because you're stranded, or to see a psychiatrist because you're seeing things that are not there. All of these problems cannot be addressed by the police. And then, of course, there's the revolving door of emergency services. So people who suffer from more chronic forms of emotional distress and mental illness, they can go in and out of the hospital, in and out, in and out. They get picked up by the cops. They go to the hospital for, I don't know, maybe a 72-hour stabilization period. They get released back onto the street, and the cycle repeats. So these are all reasons why it is a very bad idea to have police being the first responders. We can go to the next slide.
Hi, everyone. I'm Nomi Toich. I'm a clinical social worker here in Philadelphia, serving the Southwest community at the Family Practice and Counseling Network. And prior to that, I worked with survivors of gun violence based out of the Healing Hurt People program at Einstein, which allowed me to have a lot of contact with the crisis system and see just how harmful rather than helpful our crisis response can be. That what people get when they're looking for support in the middle of an emergency is a further traumatizing experience that often winds up being harder to recover from than whatever was going on originally. And we wanted to change that. So we wanted to further explain a little bit more about what the current services are that are available to help everybody understand the depth of the problem. So folks might know already, especially if you work in the mental health field or you have experienced mental health symptoms yourself, that currently the alternative to calling 911 for those in the know is to call a 10-digit number that's called the Philadelphia Crisis Line. And that is a number that is primarily serves the form of consultation and information. So that's the main goal. So we like to compare it to if you were to go outside and see your neighbor in a cardiac emergency and you were to run up and say, I know a great cardiologist. They're based out of this neighborhood and here's their business card and you should really get in touch with them and get an appointment and get yourself there and follow up. That is obviously really useful information down the road. It's not that information is bad. It's not that consultation is bad. That is great and we're glad it exists, but it's not a crisis service. What people need in the middle of a crisis is on-site care that's compassionate and skilled. So the way that can be provided is through mobile crisis units. And the Philadelphia Crisis Line does have the ability to dispatch those units, and those are going to be in the future, hopefully able to be accessed by 911 as well as the crisis line. So the crisis line is still going to have a role with dispatching mobile crisis, but currently it's just not working. There's one mobile crisis unit currently to serve all adult Philadelphians. If you think about if there were one ambulance in Philadelphia for all medical emergencies and what that would look like, it's similar. There are thousands of calls coming in and one crisis unit. So you wind up with extremely long wait times, and people report in all different parts of the city in all different kinds of emergencies, no matter how intense they are, that they'll be experiencing maybe a 6-hour wait time, or maybe the unit doesn't come at all. So those are all big issues with the crisis line currently. But the other issue is just that the crisis line is currently a 10-digit phone number that you have to know. So even if you're someone that's very aware about these services, and even if you're someone that even has one of those little stickers on your refrigerator, unless you happen to be having a crisis right in front of your refrigerator, you're going to call 911. That's what we've been taught from a young age. It's what we know. And when you have all kinds of cortisol and adrenaline pumping through your veins in the middle of a crisis, you dial 911.
So right now there has been a response, the city's response. So the response that is a coordination between the Philadelphia Police Department and DBH, or DBH IDES, which is the Department of Behavioral Health and Intellectual Disability Services, which we just call DBH. Their response has been to collaborate to create a what they're calling a co-responder model, or what they've just recently rebranded CIRT, or CERT, I've heard some people calling it. And so basically, the city has kind of heard the all of the outcry and the uprisings, particularly since the murder of George Floyd just a year ago, and cries for and organizing around ideas of divestment from the police, defund the police, of course, the Black Lives Matter network. And their response has been to propose a solution which could appear to be somewhat of a compromise. So they're really pushing two things right now. One is that the continuation of a program called CIT, which is not unique to Philly, but has been around in Philly since as early as 2007. It's called Crisis Intervention Training. And basically, it's a voluntary program that officers can sign up for if they want to. And in that training, they spend a couple of weeks learning how to de-escalate people who are experiencing mental health crises. So they learn some skills, some knowledge about that. That training has been around for quite some time, and there hasn't been any sort of demonstrated effect. They've also are now introducing a new program, which is set to begin fairly soon. It's still in its training phase right now, and that is the co-responder, or CERT team. So that is one clinician, and by clinician I mean a licensed mental health professional, and one armed police officer in an unmarked police car, riding together in an unmarked police car. So the plan for CERT is that using a script, and actually Layla, Ms. Khalil actually put the link to a Billy Penn article that includes the script way up earlier in the chat. Using this mental health script they have as a screening tool for 911 dispatchers. If they meet certain criteria on that, then they will send out a co-responder team, which is that armed officer who is CIT trained and the clinician together. And then once they come on to the scene, it is supposedly the purview of the clinician to sort of lead the scene, decide what happens next, begin their assessment process. However, the armed officer will be present the entire time and has the discretion of whether they consider the scene safe, or whether they can consider what DBH is calling a pure mental health crisis or a mental health crisis that involves safety risk. And how they typically define a pure mental health crisis is where there's no weapon present or no one talking about getting a weapon. There's no homicidal ideation, and there's nothing nearby that could be used as a weapon, which really narrows things down quite a bit. So those are the two things that are being proposed and pushed right now, and that City Council is considering funding for fiscal year 2022.
I'm going to jump in for this slide. My name is Casey Borman, and I'm a somewhat new member of the coalition, but I'm a social work professor at Westchester University. And my dissertation research was on policing interactions with people with mental illness and people who were using substances. And I particularly looked at officers here in Philadelphia. And so one thing I want to talk about is through that research, as well as through some other research I was involved in, is that, you know, as others have mentioned, you know, CIT is in part about training. It's also about having systems coordinate better together. But the training is the thing that I think the city is really focused on, and there's some real limitations to this training. There's really mixed outcomes in terms of, you know, what the benefits are. The main kind of consistent benefit is that officers feel more comfortable interacting with folks with mental illnesses. But what we found was that their understanding of like what mental illness looks like, or what scenes where somebody might have a mental illness might look like, you know, they don't differ whether somebody has CIT training or doesn't have CIT training. And one of the things, and one of the things that I kind of found through my research was that how people think about mental illness is only informed in small part through this training. A lot of it is really their on-the-job training. And what a lot of the officers in my study reported is really war stories, is these kind of extreme examples, many of which were probably exaggerated, around people with mental illnesses or with co-occurring disorders having like superhuman power, you know, one woman being able to throw 6 officers. And so what this does is it creates a real sense of fear in officers when they're interacting with someone with a mental illness. And so what we find is, you know, even officers that have been trained in CIT, they still, even if they can recognize a mental health issue, they're not necessarily using less force. And in fact, one research study done in Chicago found that some officers with CIT training actually were using higher levels of force despite recognizing the mental health symptoms. So really, police officers, you know, they go into the academy because of this idea of, you know, quote unquote, fighting crime, fighting the bad guys. And so they don't have a metric for how to handle that in a situation where, you know, the focus isn't around fighting crime. And so they continue to go in with this mentality of, you know, it's us versus them. You know, if CIT training was effective, then I think they might internalize the logic that ultimately, if people interact with others in a more humane way, it's safer for everyone, but that's not the reality. And so officers really go in thinking, you know, if it's my life or theirs, then it's not going to be my life. And so that often results in a range of different types of use of force. And that's the real concern with having police on the scene when someone's having a mental health crisis.
So is co-response a good mental health response? I think everything that has taken place in this teach-in is already going to make you not surprised by our answer, but we do not think that it is. Nikki, do you mind just going to the next slide? I didn't know if I should break it down on this one or if it's listed out. Okay, so we can just speak about it. So I think that you've heard already this evening a number of arguments against the co-response as an appropriate mental health response. The basic message that we want you to come away with this from here is that a co-response is still a police response, and a police response is not an appropriate response to a mental health emergency. We don't think law enforcement has a place as a first responder. We want to see unarmed first responders that are trained in this area, that care about this area, that want to be doing this work. We heard at the most recent hearing that City Council held on this topic, we heard the highest up person from the police department there say, we don't want to do this. We don't feel like we know how to do this. These calls get complicated, they get long, we feel stuck there. That's not the attitude of the person that is going to really help in a situation like this. We want to see trained clinicians responding to these calls, and the makeup of the teams is what we're going to tell you about next of what we do want to see.
Okay, so we're going into imagination land, right? Because we really have a strong vision, and this vision is built on both best practices, on our sort of collective personal and professional knowledge, and then also just abolitionist values. So the mobile crisis unit expansion that we believe would be best and lead to the best possible outcomes for everyone and would also save a lot of money is that, one, we definitely have a dispatch through 911. As Nomi has said many times, you don't remember that 10-digit number, you call 911. So the crisis line is great, but consultation is not necessarily what you need in an emergency. The way I usually explain it to people is that, you know, if your loved one is in the middle of a heart attack and someone walks up and gives you a business card of a great cardiologist that their brother-in-law went to, that's nice of them, but that doesn't really get the job done. You need somebody who can actually directly address the problem. And so we really need a mobile crisis team on site, on demand, dispatched through 911 so it's easily accessible. There needs to be no police presence. And in fact, the SAMHSA, the federal body that overlooks mental health, all mental health and substance abuse for the federal government, has outlined this very clearly in their recommendations, that best practice standards must include the absence of police, the complete absence of police, unless absolutely necessary. And by absolutely necessary, they're specific that a violent crime is being committed, not up to the judgment or maybe the personal fears of the person who's on site. And that these services would be supervised and run by other clinicians and peer specialists, right? We envision maybe several different possible team compositions. So you have a peer specialist and a clinician, or maybe you have a clinician and an EMT, but having that team supervised by people who are really looking to promote these best outcomes and know how to promote these best outcomes, other people who've also done this work. So not being supervised by city bureaucrats or by the PPD or anyone in the police department.
We know from all the research that's been done, from the experience of so many people who have experienced mental health emergencies, and of course from people in the mental health field, many of whom are on the call tonight, that when people are able to receive actual care in the midst of a crisis, it can set them up to actually improve their quality of life going forward and be on a trajectory towards having their needs met, their symptoms addressed, and their spirit and their personhood and their integrity honored. And so the idea that mental health emergencies up to this point are just seen as a public health, as a public safety issue that needs to be squashed, and then that's the end of the intervention, that's not acceptable. Obviously, this approach not only will be better for people in terms of addressing their mental health needs, but it's also going to save lives. And as was being pointed out in the chat, if teams like this exist in Philadelphia, they could be responding to a wide variety of situations beyond just mental health emergencies. Think about all kinds of situations where you just don't need an armed police officer entering the scene. And actually, when they do, we all know that there are potentially fatal outcomes. So we would love to see this approach get into the field, be on the ground, be operating, and we want your help in seeing that once it's piloted, it's actually used. That's something that we're going to have to really be on top of, is making sure that it's utilized once it does exist, so that we can demonstrate that this is going to benefit all kinds of Philadelphians, not only people who experience mental health diagnoses or symptoms, or people who love people who experience mental health symptoms, but anyone that has a need in an emergency that shouldn't involve an armed police officer or law enforcement.
Okay, so one of the sort of talking points that I've heard, not just about Philly, but when really sort of progressive overhauls or large scale changes have been proposed in terms of divestment from police or removal of police functions, so taking some functions away from the police. A lot of what you could hear is, well, yes, programs like this exist, but it's always on a small scale. How would you do this in a big city? Or nothing like this has ever been done before. Or we have to take it slow because this is fundamental, huge change, right? Well, as you can see from the slide, this idea is in no way novel. It's been done. It's been done with success. It's been done with in a wide variety of regions in this country, of city sizes, demographics, some rural areas, some suburban areas, some very densely populated urban areas. So anyone who's telling you that this kind of program is just really, really onerous or difficult to do or expensive or hard to implement is probably in some way attempting to preserve the status quo, because these programs have all had a lot of success. I mean, Cahoots in Eugene, Oregon, which is sort of the most known of these programs, has been around for a really long time. Also, anybody who's giving you an argument, a sort of fiscal based argument, these programs also save, as much as I hate to frame things in terms of the taxpayer, they save the taxpayer a lot of money. They are cheaper, even when you are paying a good wage to the clinicians who deserve a good wage and often don't get it otherwise. So these programs are very possible, and we're really challenging city council members, our neighbors in Philadelphia, agencies that provide these kinds of services, to imagine something fundamentally different than what we have now. And one of the great things is that we don't have to totally imagine it because it's already been done.
So I know some folks have been dropping questions into the chat as we've been going along, but the chat has been pretty active. So if you have a question and it hasn't been answered, feel free to come off of mute and say it, or if you drop it in the chat, I'll read it and some folks can answer it.
I have a quick question. I'm wondering, I'm sorry if somebody already answered this and I didn't see it, but what is the rationale that DBH is providing for a co-responder model when it has poor outcomes? Like, have they said why they're going with this model and not with something else?
I can take that if it's okay with you guys, just based
Thanks.
off of what I've heard directly from DBH. So there's really two answers to that, Lauren, and that's a great question. Because essentially for police, this is really a power grab, right? It's about not giving up any kind of mode of function because it looks like ceding power, right? Because as many have pointed out, and as Casey's research has definitely shown, cops don't like responding to these calls. So basically there's two reasons. One is sort of the on paper reason, which is that there are certain crises which are fundamentally unsafe. Why they're okay with sending out consulting bachelor level untrained teams currently to those crises, but not a mental health clinician led team, I can't answer that. It kind of defies logic in my mind, but it's sort of that they're making this division between, as I alluded to earlier, a pure mental health crisis, and one which is unsafe. And another way that this is also being kind of marketed is through this idea that it keeps social workers safe, which often really leans on racial coding, right? Because we stereotypically think of helping people like social workers as white women, right? As sort of meek white women, when in fact, most of the practitioners of this kind of service are actually women of color in this country. But basically, sorry if you heard that computer noise, but basically that's the on paper reason. Now, when we get into the nitty gritty and we ask them, okay, so what if they say they might use a weapon, but they don't have a weapon? What if because anything could be a weapon, right? You know, we're not talking about guns here. Like you can use a spoon as a weapon. I mean, what constitutes a weapon? There's really a lot of hemming and hawing and not really an answer. And what we find the second answer that we get more often, kind of anecdotally, they don't put this in the PowerPoint, but they say a lot at both DBH and in other departments, the Office of Managing Directors and other city departments, is that basically change is slow. This is a nice middle ground for now. Change is incremental and slow. We're trying to shift the culture, but it takes time. And this is a good kind of compromise for the time being.
Even though we know that once they get their hands on that, money is not going anywhere and they'll fight it forever. So thank you.
And even though they know that Black and brown people will die and other people will die in the meantime. Yes.
Yeah. Thank you. Appreciate it.
We have a question from Amanda/Catalyst. Does this plan/crisis team initiative also have parameters to respond to domestic violence and mental health challenges exacerbated by substance use?
I can't talk to the specific plan, but I think, Amanda, you're bringing up this great point, right? Like these are actually situations where people with mental illnesses are often coming into contact with police. And particularly if somebody is using a substance, it can mask the mental illness. And so I think this is something that we really have to continue thinking about, that like not all calls are going to come in dispatched as a mental health crisis. And that was why I had put in the comments, I think something we need to keep thinking about for the future is other ways to have non-police responses, because a lot of these things just are never going to get flagged, by the police, as a mental health situation.
Jess Jones is asking, can you update us on how the children's crisis response is integrated into this proposal?
I can take that again if that's okay. Sorry, guys, getting tired of my voice probably. So basically, right now there's always been a very arbitrary distinction between children's services and adult services. And I can tell you, as someone who's trained to provide both of those services, there's really not much distinction in terms of the training, but there's a ton of distinction in terms of those services. So usually everything's kept separate. Children's is just going to be a separate team than adults and vice versa, and they're not going to respond to each other's. That's the way it is now, and I have not heard anything that would change. They are right now really with the pilot, they are looking right now just at adult. When I asked about sort of what happened, or I was in a meeting where someone asked about, what happens with children's, it's sort of like kind of more of, we're going to get to that. We're starting the pilot with adults. There's basically there's no sort of good, and there's no great answer to how it would look if they had different needs, but what they're saying is that they're going to be doing consistent evaluation based on the calls they get and kind of adjusting the teams. So we're hoping that, you know, if they're getting a higher call volume for people under the age of 18 than they are for adults in certain areas or at certain times or for whatever reason, or just in general, that they would kind of adjust the teams as needed to sort of fulfill the needs. I don't personally think there's a clinical justification for always keeping those teams discrete. I think if you can work with kids, you can work with adults. If you can work with adults, you can work with kids. And if you learn something like, you know, crisis first aid, you know, it's going to make some distinctions, but it's not such a fundamentally different thing that it would need to be specialized. Does that answer your question?
Yeah, just there are 3 children's mobile crisis teams at this point, and we need a lot more as well.
Absolutely, absolutely. And to answer Kevin P's question, so I'm not too familiar with ARU2. It's a brand new program that is right now only in a few zip codes in and around the Kensington, Allegheny area and Frankfurt. I think it's like 19124, 29, a couple of other ones. I can put a link in the chat for more information. It's a new program that just started that basically addresses overdose, people looking to see anybody presenting with any kind of substance abuse issue, whether active or they just want to seek treatment. So whether in crisis or not. And that team is composed of an EMT and a mental health professional who has specific training in substance abuse, and they are responding, and that is embedded in 911. It is a 911 diversion program. It's very new, so it's small scale, and I don't have a ton of details on that, but it appears as if the city is looking to make a little bit more of a specialization for, I think, particularly people suffering with opioid dependency and related issues. Oh, Amanda already knows about it, so I'll defer.
We have a question from Kay. One question about the proposed crisis response model. Involuntary hospitalization, yes or no? Not personally a fan. Involuntary hospitalization can further traumatize someone in mental health crisis and disrespects their autonomy. Out of a cop response regardless.
A great question. And one of the arguments that we've been putting forward about why we want to see mobile crisis teams going out is that we're across the country. One of the outcomes that you see improve is more voluntary access of care and less involuntary access of care. That like when someone's able to actually establish rapport with a caring professional who is focused on their experience, is able to de-escalate, is able to center that person's needs and make an actual connection, that oftentimes a lot of other options open up besides just involuntary hospitalization, which when it's a police response is basically the tool that they have. And it winds up resulting in a lot more involuntary hospitalizations, which agreed can be very traumatizing. So it's not to say that, you know, mobile crisis units are magical and that will never happen. But one of the arguments in favor of sending out clinicians is that it can lead to fewer involuntary hospitalizations.
Greg Waldman asks, do you envision current dispatchers being trained in directing calls or hiring new ones who are already trained? One obstacle in getting some fellow union members on board with major changes to policing, including defund, is because they're afraid of layoffs.
That's a great question, and it's possible someone else knows more about this, but I do know that there's been a ton of conversation about training for existing employees, existing workers in that space. So I don't know that that means they're not going to hire new folks as well, but I have heard a lot of conversation about how many hours of training they've been doing. I know they've been doing the training in sort of groups and in waves, so they keep giving out little reports about now this percentage of the force is trained, now this percentage of the force is trained in terms of people working in the radio room. So the sense that I had gotten was that it is training current dispatchers rather than hiring a whole new group, except that they're creating some new positions, which I commented on in the chat before, that they do now want to have a mental health professional in the radio room, like in dispatch at all times, to help with the coding of calls and to help with understanding how people are responding to this new like behavioral health script that they've introduced. So those are new positions, but that's just additional jobs. I don't think it involves any layoffs, that particular role. Does anyone have any information that conflicts or Is that accurate as far as everyone knows? Seems like it's accurate. Okay. It's a great question, and it's really helpful in a way that this conversation can spur the work, is to understand more of what are things that are getting in the way that you're aware of, that we might not be aware of, that we can incorporate into our advocacy and further build out. So thanks for that.
And then I see there are a couple more questions in the chat, one of which was answered in the chat. And then the next couple of questions, yes, Nikki, I'm passing it to you to answer questions about how folks can get involved.
Yes, I saw that Liz had a question about how to get involved, and that was like a good transition point. I know we're a little bit over time, but I want to thank everyone for sticking around, because we have like a little action step. So as you heard Council Member Gim say earlier, the council like needs support, like getting like the city off of the co-responder model. So next week, Thursday, June 3rd, we would like folks to tweet at the mayor and demand that the $6 million that's currently earmarked for the co-responder be moved to mobile crisis units. And that mayor key, which we didn't talk a lot about, but that's like the, can Nomi or Julia talk more about mayor key? I felt probably important.
Yeah. Rather than these roles being city employees, they're currently contracted out, and therefore the positions tend to be pretty poorly paid and poorly treated. In a nutshell, there's more to say about that, but back to you, Nikki.
Yes, so we want the mayor key to pay the team members a fair wage, and that's the thing that we're worried about as well as this moves forward. For it to succeed, we have to have the workers that are doing the mobile crisis response be paid fairly. So another thing with co-response is that the cops are gonna make more money than everyone involved on a co-responder team. So there's no reason why for folks who are doing this important mental health crisis response who are unarmed to not make a fair, good wage from this important work. So we want folks to take action. If you register for this event, you will get a reminder email for this action, so don't worry. Also, if you are interested in joining the Treatment Non Trauma Coalition, you can follow this link, bit.ly/join-TNT. That'll take you to a Google form where you will just, click little sign up. So that is another way you can be involved in what we're doing. We've been meeting weekly to just, during budget season, we've been meeting weekly to figure out what we're doing. So you can join us in that effort and stay plugged in. So thank you, Nomi, for putting that in the chat. And I mean, that's all I've got. I'll throw it back to you, Chris, to close us out.
Thank you so much for joining us tonight. Thank you for all of my amazing TNT coalition members, and also to Councilmember Gim and to Layla from Councilmember Brooks's office for coming out tonight and talking about this issue. Please, if you want to join our coalition, follow that link. We'll also be sending out some stuff in a follow-up email. And then, as Nikki said, we're going to remind you about the action next week. But thank you so much.
Thanks for being here.
Yeah, thanks for coming, guys. Appreciate it.
So much.
Rocked it. Yay.
Thanks so much, y'all. This is like stupid exciting that this exists, and I'm really sad I didn't know about it till tonight, but really excited I know about it now.
See you at the next meeting.
Sorry, what?
I said, see you at the next meeting.
Already on it, on the bit.ly right now, joining this moment as soon as I sign off. So have a good one, y'all. Hey, Nikki and Chris.
Hey, Amanda.